consultant gynecologist, honorary professor of gynecology, University of Birmingham, requesting all your attention on the presentations, please.
Thank you so much. Thank you for those two wonderful presentations. There's a little bit of crossover with mine, so I'll skip through one or two slides, but I think it's been a lovely session for those of us who love hysteroscopy and hysteroscopic surgery. So I'm going to just run through some tips and tricks. So some essentially things over the years I've learnt in practice that can help you become a more successful hysteroscopic surgeon. And I don't know in India how well established the sort of what we call the office or outpatient setting. So this is conducting hysteroscopic procedures in conscious patients, so patients who are awake. Certainly across the UK, certainly across Europe, and it's very well established. It was less well established, this approach, in the States, but because they now, obviously in the States, it's a private healthcare system, regardless of the evidence supporting a move to the outpatient setting, the reason there's been a paradigm shift and a move to the outpatient is because reimbursement has driven that in the States. Certainly in New Zealand, I know they're doing a lot. I have fellows coming over to see my unit in Birmingham. But actually in Australia, funnily enough, there's very little in the way of outpatient. So there is a sort of move, certainly in the West, generally to doing more and more procedures in the outpatient setting, but it's certainly not uniform. Similarly in Ireland, for example, in Southern Ireland, again, I think it's due to reimbursement, there's not a lot of outpatient work. So whilst I'm not going to concentrate wholly on the outpatient setting, a lot of what I say in this tips and tricks lecture is related to conducting procedures in conscious patients. So what we're looking at really is how essentially we can optimize outcomes. So, you know, a lot of hysteroscopic surgery, as Dr. Paul and Dr. Jayakrishan have shown us, is removing either endometrium or intracavity pathology. And that might be to facilitate diagnosis, but often is to improve some clinical outcome, whether it be bleeding or problems with fertility and implantation. So if we can remove these structures completely, the theory is that then we're going to get a better outcome. So feasibility is really important. If you're going to do procedures, certainly in the outpatient setting, you want them to be acceptable. So that means a small degree of risk, rapid recovery, if the patient's awake with minimal pain. And we want the procedures to be effective and increasingly in healthcare systems cost effective. So cost effective doesn't mean cheaper, it just means that there's value for money. So, you know, the procedure is effective, but it's not costing, you know, an arm and a leg to actually buy the technology or to conduct the procedure. So I'll run through diagnosis and the operative setting, the outpatient or OR setting, and we'll look at some of the technologies and techniques. And finally, just finish with some quality assurance. I spoke about this in my first lecture yesterday on endometriosis. I do think whether doing it just for yourself or doing it on a regional or a hospital or a regional or national setting, I think it's quite nice to be able to benchmark your work. So, for example, Dr. Jayakrishan was showing pregnancy rates related to his series and against published data. And I think it's a good exercise for all of us to sort of have collect some data and understand what our practice is, and to reassure ourselves that we're doing a good job, or to actually where we feel we may be doing less of a good job, to understand why, maybe technologies, maybe set up and put remedial measures in. So I think quality assurance is important in all our practice, particularly surgical practice. So there's this, I mean, it's the emperor's new clothes, really. I've seen from many of the talks over the last 2 days that many of you are competent in ultrasound scanning as well as endoscopic techniques. But I think that there's a move, certainly in Belgium and Italy, to refer to this thing as a digital clinic. But essentially, all a digital clinic really is a combination of ultrasound and hysteroscopy in a convenient sort of ambulatory setting. And an example of why it's useful is, for example, the fibroid lecture we've just heard. You know, there are various techniques to remove fibroids hysteroscopically, and understanding, you know, the size of the fibroid, the location of the fibroid, what the myometrial free margin is, so how deep that fibroid extends towards the serosal surface, is all important, because if we can diagnose this as a combination of ultrasound and hysteroscopy, we can decide upon the setting to remove the fibroid. Is it feasible in the outpatient? Is it not? Which technologies? Do we use miniature electrodes? Do we use miniature resectoscopes or more traditional resectoscopes? Do we use mechanical hysteroscopic tissue removal systems? Do we need to down-regulate the patient with GnRH analogues? Is it likely we'll need a 2-stage, 3-stage procedure? So we need to counsel our patients. So I think treatment planning is really important. So it's not just making a diagnosis, say, of a fibroid, but it's actually then using that information to decide what to do. And I was interested in your talk, Dr. Chair Krishnan, about using the laparoscopic approach. I think there's a trial in that, because I agree, I think sometimes with the deeper, larger type 2 fibroids, to try and remove those in one go is really very difficult, and sometimes it may be possibly preferable to do a laparoscopic enucleation. So there are some questions about what we should be doing, whether hysteroscopic is always the right thing for the big type 2 fibroids. So diagnosis and planning and understanding the pathology and the potential difficulties is really important. So this is the sort of setup that people are having. They're having a sort of ultrasound machine alongside their endoscopic stacks. Now, 2005, I published a book, and in the UK and actually in Europe, there was very little outpatient hysteroscopic work. And a lot of my research and assessing new health technologies was in the outpatient setting. So myself and Jinesh Gupta, I think, has been here to speak to you. We wrote a book and published in this area. And I have to say, it's one of my better achievements that over time now, with the research work we did in the trials, it's become very much established, as I say, in the West. This is an international collaboration published consecutively in JMIG and in FVVO, which is the ESG journal. And basically, we were trying to define what we meant by an outpatient or an office procedure. And the only consistency across the international group, which was stretched from the States into Australia and all the rest of it, was that it was to do with pain control. So if you could offer no medication, local anaesthetic, oral or inhalational medications, you know, nitrous oxide, for example, then that was an office procedure. Whereas if you were going to be offering parenteral sedation, so intravenous sedation, regional anaesthetic or general anaesthetic, we felt that this wasn't really an outpatient procedure, because you would generally need an anaesthetist, and this was an operating room procedure. And it might seem an odd thing, but when we're looking at research studies in particular, or auditing our practice, we need to make sure we're comparing apples with apples. So people sometimes describe an outpatient procedure, but when you look at it, the procedure is being done under a spinal anaesthetic. Well, that's not what most of us would consider an outpatient procedure. So now if you publish any work in this area, you need to really state what level of pain control you used, and then we can determine whether that was an outpatient or an operating room procedure. And the challenge with outpatient procedures is the innervation of the uterus. The lower part of the uterus, the cervix and maybe up to the uterine isthmus, is innervated from the sacral nerve roots S2 to S4, so we can access those with direct cervical or paracervical blocks. But it's very difficult to access the fundal and corporal aspect of the uterus, which is innervated typically from around thoracic vertebrae T10 to T12. But thankfully, it's not just about anaesthetizing the uterus, which is impossible to do in the outpatient setting, but it's about other aspects, techniques, more endoscopes, minimal distension of the uterus, so that procedures are less painful and are effective and atraumatic, and they are much better then tolerated by patients. So one area that we've been looking at is there's increasing interest in what's called a fundal block. So we've got the usual paracervical, intracervical installation. Dirac cervical blocks. But they're very effective for actually anaesthetising the cervix and allowing cervical dilatation in a comfortable way in the outpatients. But there's a move now to looking at whether we should be injecting local anaesthetic directly into the fundal aspect of the uterus using a 5 French needle that goes down the working channel of the hysteroscope. And there's some data based on what's called global endometrial ablation in the outpatient setting, showing that there is some benefit reduction. By no means is the uterus anaesthetised, but it certainly seems to reduce pain. I mean, the problem is it takes a little time to put that block in, so if you're removing, say, a polyp, taking the biopsy, it's not really worth doing. But for a procedure like an ablation, that's something that we should consider. Now, my current research fellow, or one of them, is working now on this thing. We call it the green whistle, Penthrox. It's all-in-one inhalational analgesic called methoxyfluorine. We got wind of it because my research fellow, previous one, dislocated his shoulder. Not in a heroic way, like a sporting injury or something like that, but he fell over his very small dog and dislocated his shoulder. And he said when he went to A&E, he had pethidine twice and he wouldn't let them near his shoulder. But when they gave him this to breathe in and out on, he felt as though he was a little bit drunk, and they put the shoulder back and no problems. And the half-life's very short, so it was out of the system very quickly. And they use it in A&E and in ambulances, but there's very little work on it for ambulatory procedures. There's a little bit on prostate biopsies and 1 or 2 other things. But I think this is potentially something that could be very useful. The patient breathes in and out on it, they actually start to get mildly sedated, but and you can get ahead with your ablation or your operative procedure. And we're evaluating that at the moment. And in the future, it may be something, for example, you could conduct egg collections under and things like this. And the beauty of it is, as soon as the patient stops breathing on it, within 2 minutes, they are fit and able to not only walk home, but they can drive themselves home and that sort of thing. So we're interested in that. There are 1 or 2 other areas we're looking at. It's almost out. We published we wrote an evidence-based guidance, the Green Top Guideline, in 2011. We've massively updated it with reviews. It's just going through peer review. So the updated version will be available across the internet, I would have thought, in the next 3 months. But we certainly researched, and there are certain other areas around. We're using a bit of virtual reality now to see whether that helps with pain control. We're trialling that. There is some data for things like TENS machines, and certainly little things like warming saline and things can be helpful in improving pain control. And certainly in the UK, this is a report from the Department of Health, and they're suggesting now that we should be moving a lot of stuff to day case procedures, so that, for example, 50% of our laparoscopic procedures, hysterectomies, should be done as day cases. But in terms of the outpatient setting, they're suggesting that the majority of diagnostic hysteroscopies with biopsy, 90%, we should be doing as an outpatient, and around about half of our therapeutic procedures. So not the big fibroids that we've seen, but certainly the smaller fibroids, the polyps, and that sort of thing, we can do very much as an outpatient procedure. So we've seen some of the technologies. The miniature bipolar electrodes are fantastic. You've got your mechanical tissue removal systems. So these are essentially a hollow tube with a cutting window, and they either rotate to remove soft tissue like polyps, or they reciprocate back and forwards, and they can remove denser tissue like fibroids. And the beauty of them is that they do aspirate the tissue, so at the same time. So in the outpatient, you can cut polyps, small fibroids off with miniature electrodes or scissors, but then you've got to go in and out to try and get the procedure out, the tissue out. Whereas if you just use one of these mechanical tissue removal systems, there's different types, we've seen the TrueClear here, they will cut away and remove this tissue very nicely. It's a 0-degree scope, but the actual the proximal lens, the eyepiece is off center, so you can put the rod down the operating scope. And there's different sizes. The bigger ones were generally for fibroids in the OR, but the smaller ones we can do as the outpatient setting. Just a quick note on bipolar instrumentation now. We tend to be moving from monopolar, so we have a sort of lead to fluid deficit for monopolar because it's a non-absorbable medium, so there's a problem of hyponatremia with fluid overload. Whereas with saline, you generally don't get hyponatremia. You can still fluid overload the patient, but you can usually set yourself a threshold a fluid deficit of about 2.5 litres in a healthier patient, which allows us to prolong surgery, and these are some of these instruments here. There's also disposable and procedures. So the one on the right, the Lena system, is completely disposable. You throw the whole thing away, even the little LED screen, and you don't need a stack. You just need to attach your saline, and you can do a diagnostic hysteroscopy, and you can also do some they've got like a channel in the middle there where you can put little loops and snares and scissors to actually perform operative stuff. So you can actually do it without any stack or any system. You just need a stand for your fluid, and that's it, off you go, and then you throw it in the bin. And also, on that view about portability, we've got little, if you want to take a little stack with you, there's little portable ones now and things. So most of us have an established clinic with a stack, but you can actually now become a sort of ambulatory gynecologist and maybe do a home visit for a hysteroscopy. You see, the technology allows us to do that. I've touched on fluid management. There are various guidance. I draw your attention to the BSG, ESG fluid guidance, which I was an author, which does run through the pros and cons, things like using vasopressin, things about fluid management. I would just say, going back, that using pumps, if you can I certainly use a 3-litre bag and pressure sometimes. Certainly in the outpatient setting, we do that. But for the bigger fibroids and Ashermans, then having a fluid management system is really helpful because it automates your system. It maintains a constant pressure, and it's very useful. And in the outpatient, you need to have the right infrastructure. You need to have a good unit. You need to have good support staff and recovery areas. As regard technique, I'm running a bit behind, but just to say, I think we've had that demonstrated. So rather than list them here, I'll talk through with 1 or 2 videos. Adopt a vaginoscopic approach when you can. We've published good evidence to show that this is very effective and less painful than putting a speculum in. So you actually introduce your hysteroscope without the need of a speculum. To do that, if you're using a 0-degree or a 30-degree scope, you need to understand that, where your offset lens is, so that you actually align the scope correctly. If you're going to remove the fibroids in the outpatient, so this is little type 1 and you've got a little type 2 on the left. And again, this is something where you can just introduce your electrodes and remove them. And with the problem is once you start cutting into myometrium, it can be a little more uncomfortable, but certainly these sorts of fibers are very easy to do. The electrode is very small, it cuts beautifully, and you can mechanically, when it's inactivated, push the lesion so you can see exactly where you need to be cutting and pushing. So it sometimes helps you see where the limits of what you're doing. This is just like showing a sort of type 1 with a miniature electrode. What you can do is you can sort of use the inactivated electrode to sort of define your cleavage plane, to cut away the what I call the moorings, little connective tissue bridges, and then you can actually you can cut around the fibroid, and you can start to move it like a boulder out from where it is. And then this is an interesting paper showing a hybrid technique where you can actually remove the fibroid like that, or in the outpatient setting, because of the issues of retrieval, you can then put a tissue removal system in to actually, once you've removed this tactic, to actually cut it away, and then you'll end up with a nice result at the very end. I wonder if I could fast that forward. Maybe not. Okay. Well, again, interest of time, we've seen some of this. We've seen some fibroid lectures, but I'll just show you this is with a mini hysteroscope. So essentially, you've got type 0 on the left, you've got type 1 and type 2 on the other side, and it's just a matter of systematically removing the fibroid. And as you lose vision, then eventually you need to remove the fibroid chips, as we've seen earlier. The nice thing about this miniature electrode, it takes a little bit longer, but because the chips are so small, often they'll just come down the cervical canal and evacuate spontaneously, so it maintains a nice view. And you just gradually take away the fibroid. Yes, and the morcelator, again, we're saying morcelator, shouldn't really call it that, the tissue removal system. This is a miniature one used in the outpatient. So again, we can just, it goes down so it's a 5mm scope in total. It's only around about 2 millimeters this, and this so it allows you to remove fibroids nicely in the outpatient setting, smaller fibroids. Bigger, Just quickly, last thing to say is as well, this is one of my other research fellows, Preth de Silva. So we're running a randomised trial looking at removing retained products of conception and to see whether time to the next pregnancy is quicker. Because the dangers of using blind evacuation is that you may cause trauma to the vulnerable pregnant endometrium, and that might lead to adhesions and problems with fertility. So with RPOC, the nice thing about these tissue removal systems is that you can precisely remove the pathology under direct vision. And by doing that, you're minimizing trauma to the endometrium, and you can see the beauty of it. You don't have to do multiple passes of the hysteroscope, just one pass will do. And so we're evaluating this. And our pilot study was very successful. This was in Birmingham. So I'm now with a larger group. Mark Hansen-Manuel actually is the man who invented the TrueClear system on the left there. Jelena Hammerlink, we've seen one of her papers put up today, which was compared resectoscopy with tissue removal system. So we're working together between Belgium, the Netherlands and the UK to do a bigger study, which we're recruiting to now. So hopefully I can present that to you. I won't go through, in the interest of time, quality assurance, but just to say we've developed an online platform that you can access through smartphones, through the internet, which allow you to input all your data for every endoscopic, and for that matter, laparoscopic or hysteroscopic procedure. And we've also developed a quality assurance tool, which is like a standardized questionnaire that we give to patients that monitors pre, peri and post-operative experiences. And it's a national thing. It's available on the BSG website, and it allows, we've published the main data, and it allows you to actually compare your practice against standard, against the national standards. So you can, again, quality assure what you're doing. And finally, just like your wonderful meeting here today, I've set up a specific ambulatory care meeting, so a meeting where we have about 200 people that come every year, and we, on behalf of the BSG, and we discuss all things to do with outpatient ambulatory hysteroscopic procedures. So it's very popular, and we had online ones in lockdown with the Green Sea. That's my young research team. And so it's been really useful and really wonderful thing. So just to finish, hysteroscopy is common. Diagnostic hysteroscopy, should really routinely be done in the outpatient setting now. It's really feasible with very small telescopes. It's very easy, very straightforward, save you a lot of time, not having to anaesthetize your patients. So fitting coils, taking biopsies, etc. But if you've got the right technologies, you can remove small fibroids, polyps, etc. as well. So you can move a lot of your traditional hysteroscopic work into the outpatient setting. And as long as you follow a few simple tips and tricks and you have an adequate caseload, then I think you'll find you'll be very successful. Thank you very much for listening.